If you can't, just let me know. And can everybody see my screen? I'm assuming yes. This is very new to me, so I'm assuming everybody can see everything.
Yeah, I can see your screen just fine.
Perfect. Okay, I'm going to go. So I'm going to talk about basically what happens in our clinic, and it's very similar to what happens in other clinics across Canada, and why we do some of the tests that we do and how frequently we normally do them. So basically, everybody knows Fabry disease is an accumulation of GB3 in the plasmosome and lysosomes of various tissues in the body. Mechanism for cell injury is unknown, and it causes vascular thrombosis. So basically, Fabry disease affects every organ in the body. It was founded in 1898, so it's a relatively new disease. It was founded by two different physicians, Dr. Fabry, who's from Germany, and Dr. Anderson, who was from the UK. Both of these physicians noticed in a young man in his 20s, and they wrote it up in a dermatological journal, the angiokeratomas that are quite common for Fabry disease. There are over 900 defects known today for Fabry disease. And when I started about 20 years ago, there were only about 250, 300 defects. So it's grown quite a lot. And the knowledge base has grown quite a lot. When I first started, women were seen as only carriers and really shouldn't be treated. And within the first 5 years of starting in Fabry research, women were known to be carriers, were known to be affected, and needed treatment, which is miraculous. The pattern of inheritance is that if your father has Fabry disease, he will pass it on to all of his daughters. If your mother has Fabry disease, she has a 25% chance of passing it on to each one of her children. Sometimes that is even greater for some women. Fabry disease typically causes the following features: stroke, TIA, patients don't sweat, they have neuropathic pain, they have hearing loss, they have tinnitus, they have psychiatric issues, they have eye disease, they have what they call a dysmorphic face or a Fabry face, they can have cardiomyopathy, they can have conduction defects, which means that they can have like an arrhythmia, slow pulse, they can have neuropathic pain, so pain in their hands and feet, fever crisis. Most Fabry patients without treatment don't sweat much. They can have sudden hearing loss. They can have a cough and be diagnosed as sometimes with asthma and feel like they are asthmatic and wheezy at times. They can have abdominal pain, cramps, diarrhea, weight loss, nausea, and vomiting. They can also have constipation. They can have the angiokeratomas. You can develop proteinuria, renal disease, which will cause renal failure, requiring either dialysis or renal transplant. There is a fair amount of infertility with this. There's what they call arthralgias or myalgias, which are similar to arthritic pain in the joints and that stuff. You can have lymphedema, you can have edema, and you can have what's pseudoclubbing. Pseudoclubbing is when the nail beds, especially in the fingers, get quite thick. So those are some of the common features you'll see in Fabry. So if you think about it, Fabry disease affects pretty much every organ in the body. There's what they call two different types of phenotypes. So you can have a classic phenotype. So a classic phenotype would be age of onset would be early childhood. For a boy, that would be between the ages of 3 to 6 years of age. And typically what they would see would be a pain or fever crisis. Some children, some mothers, when they come in, they talk about their adult children or their children, they've had it even younger. For females, it's a little older. It's between 7, 10, 11 years of age, and that's the onset. The severity for the men is that they are moderate to severely affected. For the females, if they have a classic phenotype, they have what's called mild to severe disease. All of the organs can be involved. A common mutation would be the A143P, which is a Nova Scotia mutation. The enzyme activity for the males would be less than 5%. For the females, it could be anywhere from 5 to 100. And the GB3 deposits can be seen in all the body. For the variant type, it's usually seen in the 40s, 50s, and 60s. The severity can be mild to moderate. It's typically seen as a cardiac variant or a renal variant. The mutation that's commonly seen is the N215S variant, which is known as globally as a cardiac variant worldwide. The enzyme activity is usually 5 to 30%, and it's usually limited. The disease itself is typically limited to either the heart or the kidneys, and you will see GB3 deposits in either the heart or the kidneys. Some of the classic features will increase over time, and they can also be highly variable depending on what you have. So if you have a classic mutation, and you're a male, you'll pretty much end up with everything if you're not treated. And if you're part of a cardiac variant, you will just have it for your heart. So that's sort of what that's getting at. As we all say, men can be severely affected because of their very low or undetectable enzyme activity, and females are not just carriers. They have normal to moderate enzyme activity, but they still are affected. And that. So most patients, especially here in Nova Scotia, are found out through family history. And that's usually we get a notification that we find one family. If you find one family member, the thought process is that if you find one, you'll find anywhere from 6 to 8 other family members that are affected with disease. And usually when we see patients, we think they're positive, we'll do an enzyme level, we'll do DNA, and we do GB3. And typically our referrals for our clinic come from either a GP's office that's heard Dr. West speak or myself speak, or cardiology does a lot of referrals because they have some patients have the hypertrophic cardiomyopathy heart or cardiomyopathy in their heart, or they have a thick left ventricle. And the other places, genetics also sends us the adult patients over to our site because we see adults only. So some of the things about the care for a Fabry patient, most GPs are uncomfortable with the management because they have to manage everything, and they feel it's a very complex disease. That doesn't stop Fabry disease from other things from happening. It doesn't stop patients from having MS or patients from having cancer or anything else that can happen. Patients can have other diseases as well as having Fabry. Just want to be clear on that. And it needs a multidisciplinary care team to look after them. So basically, most patients should at least see a genetic counselor once. Sorry, I've had a cold, so I'm just a little hoarse. Genetic counselor once. You will see your nurses in the clinic or your care workers in the clinic. Sometimes you'll need to see a social worker to assist you with stuff, a dietitian for your diet. You always will see your home infusion nurses. Your family physician needs to be involved. Sometimes you need to involve a pediatrician, a medical geneticist, a nephrologist, a cardiologist, a neurologist, ophthalmologist, a gastroenterologist, and a psychologist. Typically, when you come to our clinic, Dr. West will do a brief medical history on you, a longer one if it's your first time. If you're a repeat patient, he tends to do a short medical history. How have you been since the last time you were in? Sorry. The nursing staff will also do a quick medical history if there's anything going on with you. He does a physical exam. We ask you to bring in a copy of your medications. We want to know if there's any issues that are bothering you. We always ask questionnaires. We always have questionnaires in our clinic. Some clinics will mail out the questionnaires, and the patients are responsible for bringing them back. We find it's just easier if you're sitting because you have to wait for Dr. West usually just to fill them out while you're there, and we know that they're done. And the other thing is we always approach you with studies that we're doing, because we're always looking for new and new research. So some of the physical assessments, he'll do a general assessment. He'll ask you about chest pains, palpitations, dyspnea, cough. How's your neuropathic pain? If you've had a stroke or TIA, your blood pressure, any edema, any GI issues, any problems with your diarrhea, any problems with constipation, any problems with abdominal pain. Sorry, my apologies for this. Any problems with your skin and your mood. We always check your mood, see how you're doing. For the physical exam, we'll do a blood pressure sitting and standing, pulse, temperature, and respiration rate. Dr. West sometimes will check your eyes, ears, nose, and throat. Check your JVP, so he'll lay you down and he'll get you to turn your head slightly. He'll check your venous pressure to your brain. He'll listen to your chest, your heart. He feels your abdomen, your extremities, your muscles. He'll have a look at your skin, and then he'll do ask about mood and that stuff once again. As I said, we ask everybody to bring in all their meds, and that includes prescribed as well as over the counter. And it's usually a list that we ask you to bring in. Excuse me. Listing your medications. Even herbal medications we want to know, because some of those herbal medications can interfere with the prescribed medications. Sorry, your physician will will order for you, such as your blood pressure medication. So sometimes herbal medications can interfere with blood pressure medications to treat your proteinuria or your blood pressure. We also ask about alcohol consumption and drug consumption, and that's street drugs. In our clinic, we do blood work typically for most patients. In the clinic room, our nurses will draw your blood. We always ask for a pee sample when you show up to clinic. We weigh you before you show up to clinic, when you show up to clinic. So please hold your pee. So we'll do a urine analysis, a 24-hour urine, and a urine protein-creatinine ratio. We want to see how your protein's doing in your urine. That's why we do that. We do a creatinine, urea, and electrolytes, so we would know what your sodium's like, what your protein's like, and what your creatinine's like to test your renal function. We'll want to know about your calcium, your phosphorus, your albumin, uric acid, and parathyroid. Your calcium, your phosphorus, your albumin can be all indicators if you have renal disease and are heading towards renal function. You can lose calcium, so we want to know that. PTH is called parathyroid. When you're heading towards renal disease, we want to test that, make sure it's okay. We'll want to know your CBC and your iron stores. Typically, patients with Fabry disease have low hemoglobin and have their iron stores aren't great. So sometimes we'll put patients on a ferrous sulfate or ferrous glutamate, which is an iron medication. And we'll do that for a while and test you. The other thing that we'll look at, if that doesn't work and it's really, really low, he will give you an iron supplement, like an IV extra iron in a medical day for a few weeks to bump it up if it's severe enough. We do urine GB3s, which is a marker for Fabry disease, and that goes on a pee paper. We'll do serum anti-drug antibodies if you're on enzyme replacement therapy. We will give you a rec for fasting lipids to check, because cholesterol is very bad on your blood vessels and on the organs. And you also have another disease that's very bad on your organs, so you want to test the fasting lipids. We will do a troponin level. Typically, we do a troponin level on everybody. If patients are high, when we first started to do it, we used to get called all the time because patients' troponin was high. If it's 2 times above the normal high, then we are concerned. Troponin shows if you've had a heart attack or not. Troponin can also be elevated if you have cardiomyopathy, or if you have that Fabry heart. Then the other stuff we'll do is, I said, GB3. We do also do lyso-GB3. We do CFTI antibodies, and we do biomarkers for our clinic. The biomarkers help with us for our study because we use them for other things. If people have allowed us not that we don't have to contact them. The lyso-GB3 is another biomarker that we get a report on to tell how well you're doing with your Fabry disease, as well as the antibodies as well. So some of the other tests that we order in our clinic are nuclear medicine GFR. Dr. West considers that the gold standard for renal function. It's typically done once a year for pretty much everybody, sometimes twice a year. We'll do a pulmonary function test, and that's to test your breathing, and that's done once or twice. That's done every 2 years. We will do an audiogram every 2 years. We'll do either an MRI or a CT of your brain. Some patients have had a small stroke and not realized it. They've had the stroke overnight in their sleep and haven't realized it. It's very small. But this can get them treated with therapy, and we can give them more and other medications. We will do an ECG while you're in clinic with us. We will order you an echocardiogram to be done every year, which we want to look at the ventricles of your heart. We'll do a Holter monitor. Excuse me. A Holter monitor every year on everybody, just to check out the rhythm of your heart. Some patients have gotten treated for cardiac indications for enzyme replacement therapy based on the Holter monitor. Their heart rate is dropped significantly overnight while they're sleeping and they haven't realized it, and the Holter monitor will show it. We'll do a cardiac MRI. One of the indications for treatment for women these days is late enhancement with gadolinium or fibrosis that only shows up. I'm really sorry about this. I haven't coughed all day until I started talking. With a cardiac MRI. So this will get some women treated for the cardiac MRI. And children.
Okay.
Yeah.
If you want, did you want to take a quick break or?
Let me get can I get a cough drop?
Oh, absolutely. Yep.
All right. Let me go get a cough drop and see.
No problem. What I'll do, I'll just mention. Oh, I'm sorry. You can go. I'm just talking to everyone. Just to let everyone know, we have posted information on. There's 2 patient empowerment meetings coming up. There is one in Nova Scotia and one in Winnipeg. So the information is on fabrycanada.com if you wanted to go there and check it out. We also post previous webinars that we do and newsletters. So every time we do a webinar or send out a newsletter, if you're not getting the newsletters, let us know. You can sign up on the website. But we also post them there so everyone can access them. So if you don't make it to a webinar or if you forget about it, something happens, you can access them right on the website. I don't think I can share it at the same time, but on the website fabrycanada.com, under resources, if you hold your mouse over resources, there's a menu item. It's previous webinars and newsletters. You just click there and it has everything listed there. And our events are always shown on the main page as well. And under the events, you'll have the option to go and register for them, and it has the contact information as well. If anyone has any questions, you can send an email to secretary@fabrycanada.com, and I can get back to you with the answers, or I can direct you to the right person.
All right, I'm back. Let's hope the cough drop works.
Okay, thanks very much.
Thank you. No, thank you, Ryan. I'm glad you suggested that. So for your heart, we always want to do an EKG. Like I said, we'll do it in clinic. We'll do a Holter monitor, which is like a 24-hour long ECG, electrocardiogram. It actually is a little longer than 24 hours, but it only measures 24 hours of your heart rate. We'll do an echocardiogram to check out the vessels in your heart. We'll do a cardiac MRI, which is a bit more in depth. And we do that so that patients, do that for all our patients, excuse me. For kidneys, we'll do blood pressure sitting and standing. We should wait about 3 or 4 minutes in between by the time you sit and by the time you stand. We do this just so we can see if there's a big difference between your blood pressure when you sit and when you stand. It shouldn't be that big of a difference. If it is that big of a difference, it's a good indicator that you have renal issues. The blood tests we do for kidneys are creatinine, GFR to calculate your GFR, proteinuria through a 24-hour proteinuria or spot proteinuria from the P test that we do. And we also do a nuclear medicine GFR, which is a gold standard for what your glomerular filtration rate is, how quickly your kidneys filter blood through and the waste products through your body, is what that means. And then in the rare cases, we will do a renal biopsy on patients. Some patients, we're not sure if they have Fabry disease in their kidney or diabetes in their kidneys, and we'll do a kidney biopsy. Did I miss a slide? Just that. Yeah. So some of the other things that we'll look at is we'll do GI symptoms, audiology for hearing. We'll do the eye exams for the corneal whorls or the corneal verticillata. For your brain, we'll do a brain MRI. We'll do neurologic exam, hot and cold, dull, tissue. He has a tissue. Sometimes he does. He doesn't do it as much as he used to, but he still does. And we have pain questionnaires on for your neuropathic pain. And I know everybody hates them. It's the same questionnaires all the time. It doesn't change that much. We still collect them. For non-specific treatment, Dr. West will order Dilatin, Tegretol, and Neurontin. For pain, now he started to order Lyrica. We will order an ACE inhibitor or an ARB. So something like Ramipril not so much for your high blood pressure, because that's typically what those ACE inhibitors or ARBs are ordered for. They can also be given, they've shown really good results in reducing the proteinuria in your urine. So if you have more than 300 grams of protein in your urine, your doctor really should have you on what's called an ACE inhibitor or an ARB, that type of drug, and it will help to reduce the protein in your urine. We will order you ASA, Plavix, or warfarin for stroke prevention or TIA prevention, dialysis, kidney transplant, pacemaker. A lot of patients have a low pulse or a slow pulse. Excuse me again. So we'll do a cardiac transplant for some patients that have significant cardiac issues. We don't do it, but we will refer them to a cardiologist who will. And we'll treat some vascular risk factors such as high cholesterol, and we really encourage patients not to smoke. As I said, we do questionnaires and studies, so we will, in our clinic, look at the SF-36, which is a general health questionnaire. We'll do the BPI, which is a brief pain questionnaire, and the EQ5D, which is a combination of, it's a smaller questionnaire. It's sort of in between the FS-36 and the EQ5D. And I think we're going to start doing some stool questionnaires as well, which is part of the study. We'll also look at signing patients up for the CFDI study. We participate in our clinic in the FOSS registry, the Fabry registries. Both FOSS and Fabry registries are two industry-sponsored registries. and they help to provide funding for our clinic. So we do participate. We ask all our patients if they would consent. It is up to the patient to consent. The patient always should not feel they have to participate in everything. It's up to them to say yes or no. If you feel you're being pressured, you should say no, take the consent home, walk away with it, talk to your family, and call and say yes or no. You should never feel forced to sign up to anything. And the other thing is we are always looking for participants to clinical trials. And that, once again, if you do not want to do the clinical trial, you should not feel that you have to. You can always say no. I'm going to talk a little bit about proteinuria, and I'm also going to talk about vitamin D. So proteinuria is a risk factor for cardiovascular disease, and it can also cause renal injury. That's why it causes inflammation in the kidneys. So that's why we're always on about collecting the urine, testing your urine for proteinuria, trying to get you to have a reduced salt diet, as well as making sure you're treated with an ACE or an ARB. And then ACE or an ARB, excuse me, would be something like Ramipril is an ACE or an ARB. So we want to get those medications. Patients that have had reduced proteinuria have a better outcome than patients that don't reduce their proteinuria. Vitamin D. Vitamin D has shown also to be an increase with a link of low vitamin D levels have shown to have an increase of increased proteinuria and cardiomyopathy or thickening of the heart. Vitamin D is known for its anti-inflammatory properties. It helps to decrease. My apologies. It helps to decrease proteinuria in the urine. It also helps to prevent osteoporosis. The Dr. West recommends about 2,000 international units a day for adults and between 400 and 800 for children. We will look at your specific therapy, so we will see if you're eligible for enzyme replacement therapy. He will see if you're eligible for the gene transfer study. He will talk about substrate reduction therapy is not available yet for us. We do have chaperone therapy available in Canada now, and there are some patients on chaperone therapy. And I'll just talk briefly about some of the specific treatments that are available right now. So we have, basically in Canada, we're lucky enough that we have 3 different types of treatment that are currently available. We have Replagal, Fabrazyme, and Galafold. Replagal and Fabrazyme are both enzyme replacement therapies that have been available since 2004, 2005. Galafold is fairly new on the market. Replagal and Fabrazyme are IV infusions. They're given every 2 weeks for most patients, or the majority of patients. There's a difference in dose. Replagal is 1 mg per kg. Fabrazyme is, Replagal is 0.2 mg per kg. Fabrazyme is 1 mg per kg. They're given, as I said, every 2 weeks. Some patients start out with pre-meds before that. Some patients can never stop their pre-meds because they have infusion reactions. Replagal is given over 40 minutes. It can be given in children and given in pregnancy. Fabrazyme is given no faster than 2 hours. It can be given in children. Some people have given it in pregnancy. It is, both enzymes are enzyme replacement therapies are safe to use. Galafold is new. It's come on the market this year. It's 123 milligrams. It's an oral medication that's given every 2 weeks. There are maybe 5 or 6 patients in Canada right now with both Replagal, Fabrazyme, and Galafold. You have to meet the current guidelines, treatment guidelines, and your physician would submit a request to the committee to have you approved to be treated based on criteria. And the criteria would be either a renal criteria or cardiac criteria or neurological criteria or a GI criteria or a pain criteria. You don't have to have all 5, but you have to have some things in at least one of those 5 main categories. All 3 of these treatment options would be approved by the committee. Both Repligal and Fabrazyme are reimbursed right now by the government of Canada, or by the provincial governments, I should say, not the government of Canada, are reimbursed by the provincial governments or by a private insurance, if patients have private insurance. Galafold is not yet on the formulary for the provinces. It should be by the end of the year, but it hasn't been yet. It is available through some private insurances. It's given every second day. Patients on Galafold, though, have to have an amenable mutation, and you cannot have a GFR, or your renal function cannot be less than 30 mils per minute. So you can't be heading toward dialysis if you're looking at trying Galafold. And you have to have what they call an amenable mutation. So if you're a Nova Scotia mutation with the A143P mutation, unfortunately, you're out of luck. Galafold is not amenable for our mutation. It's not recommended in children. It's not recommended during pregnancy, and there is no premiums for Galafold. And questions that we'll ask you is, we'll want to know about when you come to clinic, is your enzyme replacement therapy? Are there any issues? Are you getting your drug okay? Is it coming to your house okay? Are you having any issues with IV access? Are you having any problems with your home infusion nurse? If you have any questions for us about your enzyme replacement therapy, we're happy to talk to you about it. And if you're not on enzyme replacement therapy and we see that you meet the criteria for it, Dr. West will usually talk to you about that as well. Chaperone therapy, as I said, was approved last end of 2007. It helps stabilize the enzyme, which allows the enzyme to be transported better into certain parts of the cells where it can help break down the GB3. Unfortunately, you have to have an amenable mutation. And in Canada, there's only about 20 to 25% of the known mutations are amenable. The guidelines, I'll just briefly talk about those, and I think that's about it. So, as I said, you have to have one of the 5 categories. You have to have reduced GFR over several months, which is your serum creatinine. Why we do it? You have to have high proteinuria. That's why we do the P. Be known as a hyperfiltrator. So that's why we do the nuclear medicine GFR, hypertension, why we do your blood pressure, biopsy, if you show that you have deposits in your kidneys from your biopsy. For cardiac, it's wall thickness, increased LV, increased left ventricle thickness. In men, it's 12 millimeters. In females, it has to be greater than 11 millimeters. That's why we do an echocardiogram on you, or a cardiac MRI. You would have LVH and be eligible by ECG. That's why we do an ECG on you. So you have to show that you have left ventricle hypertrophy. LVMI, which is left ventricle mass index. So you have to show that, and that's a measurement that's taken when we do your echocardiogram. Diastolic dysfunction abnormalities are things that would show up on your echocardiogram or your cardiac MRI. Cardiac conduction or rhythm abnormalities will show up on your Holter exam. And as I said before, late enhancement will show up on your cardiac MRI, which is why we do those tests. For neurologic, you have to have stroke or TIA confirmed by a neurologist. That's why we order those tests. They then would go sudden acute unilateral, so one-sided deafness or one-sided vision loss. Would be also treatment criteria. Neuropathic pain that does not respond to standard therapy for 6 months. And also diarrhea or abdominal pain or cramps that does not respond to either of these. The same does not respond to standard therapy for 6 months. Excuse me. The guidelines can be found. Anybody can look at them. They can read the document. If you want to go see it, it's www.garrett.com. Look under resources. When the tab comes down for resources, you can find Fabry disease. You can find the latest set of guidelines there. Guidelines will be updated again next month. They'll probably go up in November on the Garrett website. And every year it broadens slightly to allow more patients to be treated. ERT is not really recommended from the physician I deal with when patients are pregnant or nursing, if they have a life expectancy of less than a year, if they have what's called IgE antibodies. IgE antibodies are those antibodies that totally wipe out the enzyme that is given in your body every 2 weeks. So it's like an anaphylaxis. It's anaphylaxis. So like you would get a bee sting and go anaphylactic. There have been some patients reported in the world with IgE antibodies. These IgE antibodies are like anaphylaxis. And if you have severe cognitive decline or severe mental decline, your inability to function normally. Question. That's it.
Okay. On the bottom of the presentation, there's a chat button for everyone except Kaye. Well, actually, if you want to click it to Kaye, you can see.
Yeah.
And if anyone has any questions that you wanted to type in the chat to everyone, you can. Or if you wanted to change it to only send the questions to me, I can read it out as anonymous. So we'll just give everyone a few minutes. If you have any questions, just put them in the chat. Can you see the chat there, Kaye? I'm not sure if you can see.
Yeah. So the question is, I believe I saw that you check the parathyroid. What are you looking for? Typically, parathyroid's looking with parathyroid. When you're on renal dialysis, your thyroid can get worse, and you'll end up with more problems. So typically, when patients are starting to head towards dialysis, meaning that Dr. West has sent them for their dialysis education and that stuff, we then start taking parathyroid. It's usually abnormal. It's usually can cause more problems. So we can give them like Synthroid or something like that to help with the parathyroid. So that's kind of what we're looking at for the parathyroid. Does that make sense?
Okay, thank you.
Julia, how come you haven't had that baby yet? I don't know.
Anybody else have any questions for Kaye while we have her? There we go.
Okay. Do you know if there's any progress with the provinces to cover Gallipoli? I think there is. I think they have been meeting with the provinces to cover Gallipoli, and my assumption is it's supposedly to be done towards the end of this year, either last quarter 2018, first quarter 2019. It should be covered. As far as I know, I think the biggest issue is price, and patients, physicians, as well as provinces are concerned about price, what they're going to price it as. So I think the price issue is maybe a big stumbling block for some provinces if they price it similar to enzyme replacement therapy. So I don't know about that. Yes. There's a question about Sarah's emailing from New Zealand, where it's probably tomorrow. They don't have many Fabry patients there. Is BPM your pulse when running more than 200 high? And I would say yes, it is. Yes, I think it is. Usually you want to target probably somewhere between 140, 160, 200 if it's consistently 200. That is quite high. I think you should see your physician about that.
Do you have time for another question or two, Kaye, if there is any?
Sure.
Okay, is there any other questions while we have Kaye still here? While we wait to see if there are any more that come in, thank you very much, Kaye, for doing the presentation for us.
Sorry about my cough. All of a sudden I started talking, my throat just dried right up.
Oh, no, completely understandable. One more there.
Just wondering about timeline for oral meds. Timeline for oral meds in that I'm not quite sure. Can you just expand on what you mean? Do you mean Galafold or so Galafold, we in Nova Scotia, we have 3 patients who are not part of our Nova Scotia mutation. They have been on Galafold since April. Well, 2 are April, 1's February. So they take Galafold every second day, and they take it going to bed. You can't take it with food. You can't take it within 2 hours of eating. So the recommendation was they take it at bedtime versus an infusion, which you have every 2 weeks. So you get a blister pack of medications, and every second day is your medication is in it, your Galafold medication is in it. Whereas and then it's a black one out. So they're instructed to write the date they start, and then they get the nurse from Innomar will call them, and it's an Innomar agency that calls them, and that's who Amicus is hired, is Innomar, and they call them to check, and we always call and check to see how they're doing on their oral medications. So I hope that answers your question. Yes, I do. There are 3 patients have gone through the gene therapy study, and there are 2 more to go, and that's it for Canada for what they call the FACT study, which was the first pilot study. So the first patient number 1 is almost 2 years. It'll be 2 years in December, November, December, maybe it's January. The second patient was he's almost, second patient is about a year behind. And the third patient was just done over the summer. And the fourth patient will be shortly. And then after he's done, the 5th patient will be in the new year. And then that is it for the Canadian portion of gene transfer. There may be, I think there is another study this company is doing, EverBio is doing another study, but they're looking, unfortunately, for enzyme naive patients this time. So Galafold has met so I hope, Chris, that answers your question. Galafold, there's a question, is Galafold still in the testing period, or has it been proved effective on patients? Galafold's been approved by both the FDA, Health Canada, and the EMA. It has been in wide circulation in Europe for over a year and a half, and it seems to be very effective. The patients seem to really like it that are there. I know in the UK, talking to colleagues that we have over there, they have had almost 100 patients on Galafold and are very happy. They have what they call a large population of patients that are amenable to Galafold, and they seem I'm very happy with the patients on Galafold, and they seem to have done very well. So, yeah, it seems to be effective for those patients that are on.
Okay, I guess the last call, if there's any other questions. Thank you for fielding so many, Kaye.
Oh, you're welcome. Thank you, everybody, for showing up.
Another few seconds for typing, just in case. I can't tell if anyone's typing or not. So. All right. Well, again, huge thank you for doing all this for us, and
Oh, thank you for having me.
hope you
It's been
feel
my
better.
pleasure.
All right. Thank you, everyone, for coming out. It should be on the website hopefully shortly. So then if you wanted to rewatch it or see any of the slides again, it'll all be there. And again, if you have any questions, just email secretary@fabrycanada.com. Thank you so much. Have a great evening, everyone.
Good night.
Good night. Thanks again.